So hi guys, and welcome to this MCQ discussion. So these sessions are very important for your exam. So please go through these questions carefully. Each and every question what we have taught teaching here is very important. So if you look at these questions, right, these are all most of your previous year questions, and most you should know each and every question how to solve in the exam hall. So I will teach you how to solve in the exam hall, and let's revise the concepts here also, so that it will become very helpful for you. So let's start our OBG discussions today. So if you look at this first question, a woman with G3P2L2 presents at 34 weeks with bleeding, pain, pain in abdomen. On examinations, vitals are stable. So vitals are stable, and baby is in cephalic, and fetal heart rate is 132. On USG, placenta is fundal and there is no retained placental clot, RPC, right? So what is the next step here? What is the next step, right? So what you are all going to do? So look at the options carefully. So what you are going to do the NST? So just tell me what is the given condition over here, right? Yes, tell me what condition we are, what are all we are going to do? What condition is this the question represents? So basically the question right here, it is like, so it is not an placenta previa. Why it is not placenta previa? Because if the placenta previa is there, the examiner could have mentioned there could be an painless bleeding, and not abruptio also. In abruptio, what they are going to use? Fetal distress, right? In vasa previa is also, in vasa previa, there also you will find the fetal distress, right? So if you look at this, so this condition is, what condition is this? So this is not about placenta previa, this is not about abruptio, and this is not about vasa previa, right? And everything is normal. Everything is normal means that the condition they are in this condition they are talking about your labor, right? So this is a question that the examiner is speaking about the labor. So how I can diagnose the labor? In labor also bleeding is present, right? So that is your show. Show is nothing but your characteristic feature of the labor is show. That is blood mixed with cervical mucus. So everything is normal. Then why you have to go for this NST? NST has no role over here, no. So I won't go for NST. So tocolytics are like, no need to give the tocolytics over here, right? So the patient is in labor, so I want to do per vaginal examination is the correct answer over here. I will explain why it is PV is correct over here, right? So why PV is correct over here is to know the cervical dilation. I am doing this per vaginal examination, okay? To know cervical dilation, I am doing this per vaginal examination. So I can give the steroids. Yeah, steroids can also be given, right? So steroids can be given up to 36 weeks, right? So steroids can be given up to the 30 weeks. So this is also correct answer. But when come to the priority, I will go with per vaginal examination. So I want to check the cervical dilatation, right? So in normal labor, we will see, right? First stage of labor, it begins with true labor pains, and it ends with an dilatation of the cervix, right? So dilatation of the cervix is very important in labor, right? So that's why I am doing per vaginal examination is the correct option. Steroids is also correct, but when come to the priority, per vaginal examination is most prior than the steroids. I am doing this because to know the how much centimeters is the cervix is dilated and all, right? So let's study some important topics over here. So let me teach you. So this will helpful for your revision at your exam time. So we know, let I write it in new page. So we know that is we have latent phase and active phase. So in latent phase, what is the cervical dilatation? It is up to 0 to 4 centimeters. In active phase, how we can go? That is greater than 5 centimeters, right? And this is about according to WHO, right? So in second stage, what will be happen? Second stage, basically it starts from fully dilatation of the cervix. So in second stage, what we will see? Fully dilated, right? So how much? 10 centimeters up to expulsion, right? So this is the event in the second stage. Latent phase we know, active phase we know. So if the examiner will ask, crowning will occurs in which stage? Second stage. Crowning will occurs in second stage. So rupture of membranes will takes place in second stage, right? So what is the rate at which cervix will get dilated? Cervical dilatation in primi, it is, yes, in primi it is how much? 1.2 centimeter per hour, right? In multi it is, yes, 1.5 centimeter per hour, right? So this is the cervical dilatation that takes place in primi and multi, right? We'll slow in some examiner if they mention whether it is in slow, it is also cervix is slow or slowly dilated, or it is also known as a dystocia, right? Dystocia is nothing but slow dilatation. So what is the criteria? If it is less than 1 centimeter per hour in active phase, right? So that is the, you can tell the cervix is slowly dilated. So when you come to this arrest, right? So arrest of a second stage. Arrest of second stage. So we'll telling, right, if the cervix is got arrested in second stage in primi, if it is 3 hours, right? And in multi, it is, yes, second stage 2, 3, 2. 2, 3, 2. Primi, multi, arrest, right? So this is the mnemonic 2, 3, 2 in second stage, right? Arrest, for arrest, right? And next we will be having this arrest of an active phase in first stage of an labor. Arrest of active means there is no change in cervical dilatation for how many hours? 4 hours. So this is about active phase arrest. Active phase arrest criteria is 4 hours. Please go through these questions carefully. These are all rank deciding questions, right? So in latent phase, we are also know 0 to 4 centimeters. So latent phase is said to be prolonged latent phase. If they ask, if it is a prolonged latent phase in primi, P stands for primi. If it is greater than 20 hours, in multi, it is greater than 14 hours, right? So these are all something which is related to the labor where students will get confused. So that's why I concised in these slides latent phase from where. So one of your question they have start latent phase and active phase are, there are your first stage of a labor from where the cervix 0 to 4 centimeter. If the cervix is dilated between 0 to 4 centimeter, we call that as latent phase. In the active phase, if it is greater than or equal to 5 centimeters, right? And now this is about second stage of labor, crowning and cervical dilatation and slow dystocia, right? So these are all very important, and these are all your exam point or exam questions. So we have revised labor also. So that's why here cervical dilatation is very important. And next, which is this is not a feature of your abruptio? Yes, tell me the answer. Which is the not a feature of an abruptio? Pain, fundal height more than the period of an gestation, warning hemorrhage, DIC. Yes, I know this question is bit tricky, but these MCQs are very helpful for your preparation. So if you answer these questions, you need not to revise this topic also. So pain, right? It's like pain is characteristic feature of abruptio. Yes. What is fundal height more than period of gestation? Yes. Then what is your warning hemorrhage? No, warning hemorrhage is never ever seen in abruptio. It is seen in placenta previa, right? So this is the correct answer over here, which is not a feature of the abruptio. Warning hemorrhage we never seen. Warning hemorrhage is never seen. DIC is seen in abruptio. Yes, DIC is the complication of the abruptio. Yes, this is also seen. So let's discuss about some points related to abruptio and placenta previa. So in placenta previa, always remember that is an painless. Okay, that is painless. In abruptio, always pain is present. Painless. And what is this period? Fundal height is equals to period of gestation, right? And warning hemorrhage. Warning hemorrhage is nothing but in the sense, first the bleeding will occur and the female will neglect it, and recurrently day by day it will be happening. So that is done, you should not neglect, right? So that's why warning hemorrhage is seen, right? So DIC is mainly, why DIC will occur? DIC is very dangerous, right? If you put the cannula also, from the cannula side bleeding will occur. That much dangerous is this DIC. So DIC will occurs in abruptio, mainly due to thromboplastin, right? So this is about the abruptio. So then one thing, what about the uterine tone? Uterine tone in abruptio placenta. In placenta previa, uterine tone is soft, non-tender and relaxed, right? SNR is the mnemonic. So this is very important, soft, non-tender and relaxed. In abruptio, what is the uterine tone? So don't confuse, this side is placenta previa and this side is abruptio. What is the uterine tone? It is increased, so tone is harder, tensed, right? So what about the color over here? This is an dark red and this is about bright red, right? So these are all how you can differentiate between placenta previa. And what is the management in placenta previa? Always CS, cesarean section. Here I can go with vaginal delivery, right? So this is all about, so this is very important. Uterine tone is harder, tensed and dark red, relaxed, and uterine is not relaxed, hard, tender and all. So this is the how you can differentiate painless, pain, and also this is about the characteristic feature and how do you differentiate. I taught you the management and I taught you this also. So this is about how you differentiate. This is very important topic between abruptio and this placenta previa. Yes, next question. A 32 years old woman presents to the delivery suite complaining the bleeding per vagina. This was bright red. I taught you bright red. Just now I explained you. So this is the hint in the question. So you are reading the bright red in color and painless. Look at whatever the feature I have highlighted is, these are your all your exam questions. An ultrasound scan at 12 weeks had confirmed a twin pregnancy. What is the likely diagnosis over here? Yes, this is painless and bright red color. What in which placenta? That is your placenta previa, right? So this is about placenta previa. So how so why I marked up placenta previa? Now you guys know. One is bright red, right? In abruptio I thought dark or altered color you can see. And what are all the risk factor of placenta previa? One is your multifetal pregnancy. So if the examiner, if they won't mention painless or red also, then you have to mark this. If the twin pregnancy is present, then you have to go for this multifetal pregnancy. And next one is your multiparity, right? And increased age and previous cesarean section, right? So these are all right. And smoking is a risk factor for abruptio, right? Smoking is risk factor for abruptio, and smoking is protective in preeclampsia, is protective in preeclampsia, right? So this is about the smoking related disorders. So these are all about how you differentiate between placenta previa and abruptio and normal this labor and all. So pain, painless, these are all very important. So I have taught you. So yes. And next question is, which is not seen with uterus got ruptured? Which is not seen over here? Yes. Tell me. So if the uterus will get ruptured, abdomen will become tender, yes. Bleeding, yes. And now students will get confused between next two options, right? So these are all like basic. If you know the concept also, you know, if the uterus is ruptured, the abdomen will always become tender, right? And what about bleeding? Bleeding will occur. So what kind of bleeding? Bright red, right? So bright red, I thought two conditions, placenta previa and in your uterine rupture, right? And fetal distress? No, fetal distress is not like something which is seen in severe distress condition, right? So it is a fetal complication, fetal, right? And superficially felt fetal parts. Yes, if you look at this uterine rupture, the parts you will felt superficially, you will feel the parts, right? So this is also correct. And which is the wrong option over here is fetal tachycardia. Fetal tachycardia. Why fetal tachycardia is? So fetal tachycardia is seen in distress, not in ruptured uterus, right? Fetal tachycardia is majorly it is seen in severe distress conditions, right? So that's why fetal tachycardia is not seen in ruptured uterus. Okay. So the correct option over here is ruptured uterus. Correct. Fetal tachycardia is never ever seen. So, and next we move to fifth question. A lady presents at 37 weeks with a moderate to severe vaginal bleeding. Yes. Her vitals are stable. Yes. On USG placenta is over internal os. Okay. And which of the following is the management of her? Yes. So go through this question carefully. A lady presents at 37 weeks. A lady presents at the 37 weeks to moderate to severe vaginal bleeding. Her vitals are stable. Yes, her vitals are stable. On USG, placenta is over internal os. Okay. Which of the following is the management of her? So, what condition they are talking about here? Whether it is an abruptio, uterine rupture, or placenta previa. So, what condition? Yes, this is the placenta previa. So, how I diagnose the placenta previa, and I will teach you one more concept over here, right? So, about the internal os. So, I have an image for you. Yes. Look at this image, right? So these are all the types of an placenta previa. So if you look at this first image, look at the first image carefully. The placenta, where it is located, right? So if you look at this first image, the placenta is located, it is not coming near to the internal os, it is away from the internal os. So this is your type 1, it is type 1 placenta previa, it is also known as your low lying. So look at the image carefully. So this is your internal os. Placenta is not coming to the internal, it is up 2 centimeters away from the internal os. So that's why this is your low lying. Why I call the it is 2 centimeters away from the internal os. So this is your low lying. So type 2 placenta previa. If you look at this placenta, so it is coming until margins, right? So this IBQs is very important. So this is your marginal placenta. Type 2, it is also known as your marginal placenta. And when we come to this type 3, yes, type 3 is also known as your partial. So why I am partial? So look at the placenta, it is covering the internal os but not completely. Most of the placenta is over here only. It is covering only some portion of the placenta. So that is, this is an partial. This is your partial. And this is about your type 4. If you look at the type 4, what is present? So whole placenta, right? Whole placenta, this, it is covering at the internal os. This is your type 4 or complete or central. Type 4, it is also known as a complete central, right? So this is the how you differentiate between the low lying placenta, marginal placenta, partial. Image based questions are very important. So This is about the question over here. And next we move to our discussion. A day presents at 37 weeks with a moderate to severe vaginal bleeding. Her vitals are stable on USG internal os. So this is an condition of, yes, placenta previa. So what is the following management for her? Yes, tell me what is the following management of in her? So artificial rupture of a membrane? No, artificial rupture of a membrane. Why you will do? You will do in the second stage of a labor in which normal NVD is possible. So induction of labor is also no. Why I will induce? So I don't want this normal labor. No, then what is the use of using this ARM? Artificial rupture of membrane? These are all done for the NVD, normal vaginal deliveries, or like induction of labor is also for vaginal delivery. So you guys will come confused between these two concepts. So I will teach you expectant management and cesarean section. So now you easily eliminated this. So why? There is no NVD in placenta previa. I can do some expectant management or cesarean section is the option over here. So why I am not marking this expectant management? So most of the students, what they will do is, after looking at the vital stable, they will go with this expectant management, right? But that is absolutely wrong in this question. Because why? If you look at this lady with a moderate severe, her vitals are stable, but look at the period of gestation. At what week she is coming? She is coming at 37 weeks. No, so then what is the use of doing this expectant management? Look at you, I will highlight it over here. She is coming at 37 weeks. At 37 weeks we won't do this expectant management, we will do directly cesarean section, right? So this is why I did not mark this expectant management over here. Okay, so this is about so where we will do this placenta previa expectant management, when I can do, if the mother is, yes, so expectant management when I will do, if the vitals are stable. So period of gestation should be, or it should be less than 36 weeks, right? 36 weeks or 34 weeks, right? Some regime will be for Mcq Johnson regime, right? So that will be used for this condition. So expectant management, so Mcq Johnson's MEDCAFE Johnson's regime will be used, right? So at which weeks? At 34 or less than 36 is nothing but your approximately you can done at 34 weeks. If the mother comes at 34 weeks, then I can do. But she is coming like so I will teach you very clearly, don't confuse. So if it is at the 34 weeks, you can go for this expectant management. After 36 weeks, you always do CS, or 36 weeks or 37 weeks, you always should do cesarean section. So vitals are stable, don't go for expectant management. Look at the week also, it is the female, she is coming at 37 weeks, so that's why you won't go for this cesarean. So what regime will be followed in the expectant management? MEDCAFE Johnson's regime. If they ask, then go with this. So what regime is followed in expectant management? So what I will do in expectant management? Like I will maintain the hydration status, I will resuscitate the patient and all, right? So what is used? MEDCAFE Johnson regime, right? So to follow this, what should be condition? Fetal heart rate should be normal and mother should be stable and weak, right? And what weeks we are doing this, right? So this is about the bleeding, or this is about how to management of the placenta previa, right? So yes, next question is, look at this, repetitive late deceleration will indicate. So what? Yes, cord compression. No, cord compression is the different, right? So it is done in variable deceleration. So cord compression you will see in variable deceleration, right? And fetal acidosis is like nothing. So fetal hypoxia, yes, it is seen in UPI, uteroplacental insufficiency. Uteroplacental insufficiency. So this uteroplacental insufficiency, it leads to which deceleration? Late deceleration, right? So this is the correct option over here. So one of the fetal hypoxia will leads to uteroplacental insufficiency will leads to fetal hypoxia. This UPI is characteristic feature of your late deceleration, right? So this is about, so fetal sleep, right? So whenever fetus will, remember one thing, whenever fetus is sleeping, all your NST will become non-reactive, right? So your NST will become non-reactive. Let me teach you NST. If the acceleration is less than 2 accelerations in 40 minutes, that is an non-reactive, right? Non-reactive or abnormal NST. So for reactive or normal, very important, very important, reactive or normal, how much fetal acceleration should be? Greater than or equal to 2 accelerations, right? And what about accelerations? How many accelerations? Fetal acceleration is very good. Fetus is having the fetal acceleration is a very good condition, but fetal deceleration is a very bad, right? D for deceleration, B for bad. Fetal, whenever you should get the fetal deceleration, you should be like an very, you should take an immediate steps to terminate that. So that's why if the acceleration, so how much fetal heart rate should increase by 15 beats per minute in how many? 15 seconds. This is about normal fetal accelerations. So if you look at the fetal decelerations, you should not a normal condition, right? And one more is if they ask you sinusoidal wave-like pattern is seen in, like the sinusoidal wave-like pattern is seen in, yes, fetal anemia, right? So we thought early decelerations we completed, late deceleration variable. In early deceleration, what is compressed? In early deceleration, what is compressed? Head. Right? Head is compressed in your early deceleration. So they will ask about this. So and they will ask you some graph also, how to differentiate that. I will show you over here. Look at this, right? So in this NST, right? This is a normal NST or NCTG. So look at this part, right? This part is your uterine contraction and this is about your fetal heart rate. Okay, uterine contractions, fetal heart rates, uterine contraction and fetal heart rate. Suppose in early deceleration, if you look at this, the dip which is coming down, the dip which is coming down here, I have marked, right? They are coinciding with the uterine contraction, right? So they are coinciding with the uterine contraction. I will zoom it for you. So look at over here also. Look at this also here. So what they are doing here? So all these fetal heart rate and uterine contractions, they both are coming together, right? They both are coinciding. They are both are coinciding, right? So they both. So look at this. This is the dip over here. I will zoom in maximum for you. So look at this dip, right? So this dip, and then in exam you draw the straight line over here like this. So if coincides with the uterine, if both this fetal heart rate dip and this uterine contraction, so both they are coinciding or both they are touching together, both are equal, that is your early deceleration. So I will draw it for you. So this is, so hand draw with me so that you won't forget. This is fetal heart rate. And next I will go with this uterine contractions. Uterine contractions, right? So both, what about both these dips? They are coinciding with each other. So that's why this is your early deceleration, right? And next, look at this, right? So look at this dip. They are not coinciding with each other, right? And mark the straight line over here, right? So So this is the dip over here, and if I do like this, they are not coinciding with the each other. Look at this, which I have showed you in a red, right? So this mark, right? So they are not coinciding with the each other. So that is, this is about your late deceleration, right? So fetal heart rate and uterine contraction, right? So look at the where the dip is over here, right? Over here, right? So look at this, they are not coinciding with the each other, right? So this is about late deceleration. So go through these diagrams carefully, right? So late deceleration is the characteristic feature of your UPI, uteroplacental insufficiency. Early deceleration, head. Okay, and next late one is, late is nothing but your variable deceleration is nothing but your variable deceleration, mainly it is due to cord. Look at this, there is no correlation only between this. So look at this dip, right? So look at this, they are not at all, they are like going away from the each other, they are not at all going together. So I will hand draw for you, right? They are not at all coinciding with each other. So this is about your variable deceleration, mainly it occurs in your cord compression, right? So this is about how to different, this is very important, this fetal decelerations, right? Early deceleration, late deceleration, variable deceleration. So what is worst kind of deceleration is your late deceleration is worst kind. Why? Uteroplacental insufficiency, fetal will get distress over here, right? And this variable deceleration cord is get compressed, so you have to change the position over here. So this is about early, late, variable. I taught you what are all the causes, so I explained in a very short duration of the time. So this is how you will revise at your exam time, right? MCQs. So next is bishop will include all except, yes, is bishop score is will include all of the scores except, yes, this is done. So bishop will include everything, cervical dilatation, yes, position, yes, presenting part, no, length of the cervix, like length of the cervix. So see, in exam every time you if you give the question, you can easily eliminate, if you read properly, you can easily differentiate the two options. So you can usually eliminate the two options, that is cervical dilatation and position, you know. These are components of your bishop. So then what about your presenting part? No. Presenting part is like completely different, and length of the cervix is also not a part of a bishop. And this is a part of your modified bishop, right? So this is a part of your modified bishop score. Modified bishop. So both are correct. C and D are not included in bishop. When compared to this, presenting part is not at all included in your bishop score, right? So that's why I am marking this C. If C couldn't, if C is not there in the option, then I can go to the option D. But C is present in the option. Presenting part is like completely different. No. So let's discuss, right? So what are all the components in the bishop? Somebody, they will be using this mnemonics, right? Delhi police employed special commandos and all, right? So what is the components of bishops? Very important. Dilatation of cervix. Delhi police employed special commandos. Position of cervix. effacement of cervix and Delhi police employed special commandos. S stands for your station of the fetus. Yes. And next, one more C stands for your consistency. So these are all Bishop score. So in modified Bishop, this effacement is replaced by length of the cervix. Can anybody tell what is the score that should be? Bishop score is greater than or equal to how much it is be favorable, right? Yes, tell me. Yes, if the Bishop score, what should be the score is favorable for induction of the labor is performed or not? So if everybody greater than or equal to 6 is favorable, if the option is there greater than or equal to 9, then you first go with 9, not 6, right? So if the option it is having both 9 and 6, then first priority is 9. So generally greater than or equal to 6, you can induce the induction of labor will be happen. So if it is greater than or equal to 9, it is very good score, right? So then go for this. If 9 is present, go for 9. If 9 is not there, then go for 6, right? So this is about Bishop score, components of the Bishop score. Yes, and next one more important question. During delivery, the perineal muscle got tore, but not the anal sphincter. How will you classify this? Yes. So we know in first degree what will tear? First degree vaginal mucosa and skin. Right? Vaginal mucosa and skin will get torn in your first degree. In second degree, perineal muscles get torn, but not anal sphincter. In third degree, anal sphincter. In fourth degree is your rectal mucosa, right? So this is about, I have the image for you. I will show you it now only. Yes. So look at the diagram carefully. Only vaginal mucosa is torn. That is your first degree. Vaginal mucosa is torn. That is your first degree. Right? So only this part. Right? So if you look at this over here, the muscle is also torn over here. Muscles are also torn over here. So that is your second degree. Perineal muscles are torn. That is your second degree. When you come this third degree, anal sphincter, here anal sphincter is also torn. And if rectum is torn, that is your fourth degree. Right? And IBQs are very important. So I will zoom it for you. First degree, vaginal mucosa. Look at the arrow. In second degree, perineal muscles are torn. And in third degree, anal sphincter is torn. In fourth degree, rectum is torn, right? And this is how you differentiate between the perineal the tears and all, first degree, second degree. Suppose if anybody will ask, how do you repair this first degree and second degree? We can repair it both this in your LR. Labor room only we can repair, right? And this third degree and fourth degree we cannot repair in the labor room. We should take the patient to your OT, operation theater, right? So this is about how do you repair. So ideally, if the repair can take place between 12 to 24 hours, what happens if the patient will come after 24 hours? The repair, this, so what I am teaching is about first degree and second degree, you know, they are completely they are repaired in your labor room, and third degree and fourth degree they are repaired in your operation theater, right? And that repair also should take place between 12 to 24. If the repair it takes place after if the patient will comes after 24 hours, then when you are going to repair? After 2 to 3 weeks. So if patient comes after 24 hours, repair at, yes, you repair at 2 to 3 weeks. Okay, and this is about perennial muscle tear and early degeneration. So this is about next MCQ. So next we further move on to our one more MCQ. Station. What is the station? So I have included all kind of questions, so which are very easy and which are very simple, and we are combining all the questions, so that will, you feel like that it could be in a main exam pattern. So what is the station when the leading point of the fetal head is at ischial spine? The fetal head is at ischial spine, right? So that is your 0, right? So minus indicates above the ischial spine, right? So if the fetal head is above the ischial spine, minus indicates above the ischial spine. 1 indicates 1 centimeter distance, right? How much distance the fetal head is away from the ischial spine, right? So plus indicates below the ischial spine. So this is about 1 centimeter, and plus 2 centimeter is nothing but below. Plus indicates below. How much? 2 centimeter of the ischial spine. So if they ask crowning will occur at what level? Greater than or equal to +3, right? So this is about ischial spine and their diameters. So next we have studied about this. Next, when compared to this, come to this 10th question over here. Compared with midline episiotomy, what is the advantage of mediolateral episiotomy? So we will be performing mediolateral episiotomy, right? So what are all the advantages over here, right, when compared to this midline, right? So look at this question carefully. Ease of and repair. So repair is very tough in mediolateral, even though mediolateral is preferred. Why? I will teach you. So ease of repair is done, and less extension. Yes, less extension is nothing but, if you do this mediolateral episiotomy, there will be a less chances to involve anal sphincter. So that is the reason why we will perform mediolateral episiotomy. Why we are performing mediolateral episiotomy is, in midline episiotomy or in other episiotomy, there will be a chances of cutting of your anal sphincter. But when you come to this mediolateral episiotomy, anal sphincter can never be cutted over here. That's why less extension. The scissor itself, it extends very less, right? So that's why this will prevent the tear of an anal sphincter. Less extension to sphincter. So I can preserve this anal sphincter. I can never cut the anal sphincter if I do this mediolateral episiotomy. Even though more muscles are cut, more these muscle fibers are cut, more bleeding will occur and very tough to repair. Even though I will go with mediolateral episiotomy because of only one reason. Because anal sphincter is never ever involved in this, right? So that's why I go with this. And less blood loss, no, and less breakdown, no. Less extension is nothing but I am giving less damage to your sphincter, right? Less extension to the sphincter, right? So this is about, so tell me if episiotomy is routinely needed. No, episiotomy is not at all routinely needed. Routine episiotomy is not, does routine episiotomy is nothing but in all the cases routine episiotomy is not needed. So which degree tear? Second degree. Episiotomy leads to, these are all episiotomy points. Second degree tear, right? So episiotomy is given at which? At crowning. At what level? At crowning. Episiotomy is given at crowning, right? So what maneuver is performed, right? So what maneuver is performed to prevent the perineal tear in second stage of labor? Rittgen maneuver. Modified Rittgen maneuver is used. right? So to prevent the perineal tear, right? So why it is done? To prevent perineal tear. So if they ask what are all the muscles that are cut in episiotomy, muscles which will be cut is your bulbospongiosus, and which is one of the type of your, and bulbocavernous, and next one is your transverse perineal. So there are two types of muscles in transverse perineal muscles. One is your superficial, and next one is your deep, and next is your part of levator ani. Which part? Pubococcygeus. Pubococcygeus, right? So these are all the muscles cut in episiotomy. Very, very important. So these are all the muscles which are cut. So if which is not cut, then go with options other than this, right? Bulbospongiosus, bulbotransverse, superficial or deep, and levator, enamel, and pubococcygeus. These are all the muscles which will be cut in your episiotomy. So if they ask which is not cut, then go for with other options. So next, let's move to the pelvis, and pelvis is also, all these MCQs are very important and they have been asked in your exams also. So please go through these MCQs carefully. So which pelvis has convergent side walls, prominent side walls, and narrow pubic arch? Yes, they are talking about male pelvis, right? So why? So prominent, if you listen in pelvis, definitely you should go with this only one option, that is your android. Prominent ischial spine is seen in your android pelvis. So this is an typical male pelvis. Okay, getting. So this is about typical male pelvis. So why I have marked? Due to this, I have in exam I have seen this word, prominent ischial spine. Right. So this is an characteristic feature. So what is the subpubic angle? Subpubic angle is less than 90 degree. So android pelvis, it is also known as your male pelvis, I thought, and it is commonly seen in your OP position or ROP, right? And this is about android pelvis. So let me show you the diagram, so that will be helpful for you. So they can ask IBQs also. Yes. Look at the first one. First one is your, yes, this is your gynecoid pelvis. This one is your gynecoid pelvis, and this is the most pelvis that will be suitable for the vaginal delivery. So this is your gynecoid pelvis. It is also called your female pelvis. Okay. So what about this android pelvis? So this is, I taught you. This is about, see, look at this. This is about your prominent ischial spine. Is seen in which? Yes, is seen in prominent ischial spine is seen in android pelvis. So in platypelloid pelvis, right? So what is the shape? Trans-oval, right? So this is an platypelloid. So what is this? Transverse diameter is greater than AP diameter. So in anthropoid pelvis, this is your oval. AP diameter is in oval. So if you look at this, transverse diameter is oval in your platypelloid. In anthropoid, this AP diameter, it is oval over here, right? So here AP diameter is greater than your transverse diameter in which? In anthropoid pelvis. So this is how you will go with this. So how to differentiate between the, so android pelvis, anthropoid pelvis, gynecoid pelvis, female pelvis, male pelvis, so platypelloid pelvis, transfer diameter, and this is about how pelvis and pelvis anatomy and IBQs of the pelvis. So one more in last they have in necklace pelvis. What do you mean by this? Necklace pelvis. What do you mean? Only one ala of sacrum is absent. What about Robert? Both ala are absent, right? Suppose I will teach you what do you mean by this necklace pelvis is only one ala of the sacrum is, suppose imagine so this is your sacrum, and sacrum we are having these alas. This is your ala. This is the normal sacrum. Normal sacrum at the side it is having like wings like a structure, like so wings like a structure, so that is your ala. If one ala is absent, so only this part I am erasing this. If one ala of sacrum is absent, that is your necklace pelvis. That is your necklace pelvis. If both the alas are absent, right? If both the fans are absent, right? Wings are absent, that is your Robert. Remember, for Robert there is no wings, right? No hands. For a person name is Robert and he has no hands, so both are absent. So this is also they have been asked, right? So that's why I explained it over here for you. And this is about anthropoid pelvis, android pelvis, gynecoid pelvis, platypelloid pelvis. So this is how we will revise it over here. And next, coming to the next question, the following are presumptive signs of pregnancy except, very good question. So presumptive sign is nothing but where the female she herself can know the what are all the signs that is present, right? So this is the cholasma is also, yes, she can feel, right? So this is mainly to melasoma presumptive sign. And next, this linea nigra is nothing but your stretch mark that is seen between this xiphisternum and between this pubic symphysis. One mark is present, straight mark, that is your linea nigra. And maculopapular rashes are like completely false. And stretch markers also the examiners they can be seen over here. So this is about presumptive sign. So then what do you mean by this probable sign? Probable is nothing but in which doctor sees on bimanual examination, right? So this is about this, and I will discuss some points over here. In quickening, so what is this quickening? Quickening is an what? It is an presumptive sign or probable sign? Yes, it is a presumptive sign. It can be felt only by the mother, right? So quickening is an presumptive. So next question will arise, when does this quickening will see? In primi it is 18 to 20. In multi it is 16 to 18, right? So average 18 weeks. So both averagely 18 weeks, right? So this is about quickening, right? So then this is then they will ask, then a fetal heart sound is heard in stethoscope by 20 weeks. If they ask internal ballotment 16 to 20 weeks and external ballotment 20 to 24 weeks, and next lightening it occurs at which trimester? Third trimester. Yes, in third trimester at what week? 37 weeks, right? So these are all important one liners, they can be asked in your exam, right? So all of the following are produced by the placenta except. Okay, so I will solve this question. So prolactin, mainly it is secreted by pituitary, right? So prolactin is secreted by your pituitary or decidua. It is not secreted by your placenta. So the correct option over here is prolactin. What about this HCG? It is secreted by placenta. HPL? Yes, it is secreted by placenta. Estratriol? Yes. So these are all that they have been asked in one of your exam. So estratriol is also secreted by the placenta. Yes. So let me discuss some this specific estrogen of pregnancy, which is mostly specifically seen, that is your E3. E3 is nothing but your estrol, estrogen triol, estriol, TRIOL, TRIOL, right? And main estrogen in post menopausal female, that is your E1, which is your estrone, right? And main estrogen in reproductive age is your E2, that is your estradiol, estradiol, right? Estradiol trial. So this is very important, specific. So then if you ask this, what is the order of most potent? Most potent is nothing but your E2, E1, E3, right? So this is about so which is used in Down syndrome triple test and all. Estradiol, right? E3 is used. So we know that, right? So all this is about estrogen. So this is about this question. So prolactin is mainly, it is secreted by pituitary, not by the placenta. HCG, HPL and estriol, right? These are secreted by your placenta. So all of the following causes oligohydramnios except. So anencephaly is nothing but skull is absent, so that how it will leads to the oligo? It leads to the polyhydramnios. So this leads to your renal agenesis. Yes. So we know what is the major source for an amniotic fluid is nothing but your fetal urine, right? Fetal urine is the major source for an amniotic fluid. Suppose if there is a condition such as renal agenesis, if the kidney is not functioning properly, then how urine will get formed? So that's why you see oligohydramnios and poor placental perfusion. If there is a blood loss is less, then you will find this oligohydramnios. In postpartum pregnancy also you will find this oligohydramnios, right? In all these below three, renal agenesis, poor placental perfusion, and postpartum, you will find this oligohydramnios, except this anencephaly will cause to uh, polyhydramnios. Why polyhydramnios? Because absent of swallowing reflexes. Absent of swallowing, if the baby cannot get swallowing, then that these production is taking place and they are not going back to the baby, right? So baby will swallow. So baby, if the swallowing reflexes is absent, so that leads to your polyhydramnios. In oligohydramnios, fetal itself is not at all going urine, or it is not at all producing the urine, so that leads to your renal agenesis, right? So this is about how to differentiate over here, right? And this is about, so next, which of the following is an always indication of cesarean section? Abruptio, I thought you abruptio, like I can try vaginal delivery. In severe preeclampsia also I can try the vaginal delivery. In preterm labor also I can try this VD. In active genital herpes I never ever do this VD, vaginal delivery. I always prefer cesarean section. So the correct option over here is active genital herpes, right? In abruptio, I can try vaginal. Here also I can try vaginal, right? So what are all the conditions like in which I have to do this cesarean section only? So contraindication for induction of labor. One is your placenta previa and one is your active genital herpes and next one is your vasa previa, fetal bleeding, and next is your transverse lie, and next is your contracted pelvis. I am writing all that so that you won't remember, you won't get forget over there in the exam hall. And in your CPD, cephalopelvic disproportion, in your late deceleration, now only I thought, so I never going to induce, I will always perform cesarean section over there, right? And these are all the where you will perform these contraindication of this vaginal delivery. You should always present. And one more is these are all contraindication of induction of labor, and one more here classical cesarean section, right? So this is the reason where I will won't be doing these what induction of an these normal vaginal delivery is not possible. I will always go cesarean section because active genital herpes is an infection and it can transmit to the baby also. So that's why I will go for over here. And next is, which of the following is contraindicated for instrumental delivery, right? In maternal cardiac disease, like I can go because in maternal cardiac delivery, I will use this instrument because to cut short or to shorten the second stage. In fetal distress also I will do. Why? Because to decrease the duration of the second stage, right? If I apply the instruments, the baby will deliver the fast. So that's why here also in transverse lie, what I will do, always I have mentioned, always you have to do cesarean section. Because in transverse lie there is a chances of an cord prolapse and all, right? And in prolonged second stage, yes, in prolonged second stage I should apply my instruments. So that is the use of the instrumental deliveries. In prolonged second stage, I will never apply, I will apply my instruments over here in transverse lie. So this is about how I will do over here. So I will teach you some points where you should never use these instruments. So instrumental delivery is contraindication of instrumental delivery. Sorry. Very important sessions, these are all. So I will be teaching. One is your contracted pelvis and one is your cephalopelvic disproportion, which is in this molding is present. And next one is your HIV positive. And next one is your fetal coagulopathy. Yes, getting HIV positive, fetal coagulopathy, and next one is your osteogenesis imperfecta. So these are all the conditions where instrumental delivery should not take place. So whenever there is an instrumental delivery is contraindicated, there is a contraindication of applying for vacuum also. So here vacuum is also contraindicated. So if they ask where the vacuum is contraindicated is instrumental delivery, and these are all the contraindications for your both forceps and vacuums. So in instrumental delivery, what we will do, right? We will use this forceps. So that is your forceps. Forceps are contraindicated in same. Instruments is nothing but your forceps only. No, wringless forceps, Keenan forceps and your Piper's forceps. These are all the instruments which are used to deliver the baby. So contracted pelvis. So I will teach you now where forceps can be used. Remember the word what I am telling you. Forceps can be used, but vacuum is contraindicated. Vacuum is contraindicated in these conditions also. I will teach you some conditions where specifically vacuum cannot be used, but instruments can be used. So vacuum is contraindicated. So these are all the conditions where I will teach you vacuum is contraindicated. One is your very important prematurity, getting, and next one is your face presentation, and next one is your after coming head of breech. So this is the three conditions where you should never ever use vacuum. One is your prematurity, face presentation, and after coming head in breech, right? These are all the especially conditions where vacuum should never ever never be used, right? So this is about where the vacuum is contraindicated. So I have some forceps for you. Yes. Look at these diagrams carefully. So look at this. So I will teach you how in exam all within 30 seconds you can identify the forceps, right? So look at the first, if you look at the forceps is having three parts. One is your blade, shaft and handle. So forceps are two types. One is your short forceps and one is your long forceps. So in short forceps, the length of the blade and length of the shaft and handle are equal, right? In long forceps, length of the blade and length of the blade and shaft and handle, they are not at all equal, right? So this is how you will differentiate. In OBG, only three forceps are used. One is your wringless, one is your pipers, and one is your keelants, right? So these are all the forceps which are being used. So wringless forceps is your short forceps, right? And remaining next your keelant and your piper forceps are your long forceps. So whatever the image I thought you know now, I will explain it over for you. So look at this. So this is the blade and this is about shaft and handle. So whenever if you see at this diagram, so this is the part where the blade will get end, right? So until here it is the blade, and look at this. What is the length of the blade and look at this length of the shaft and handle. They are equal, no? Look at this, they are equal in size. So that's why this is an which forceps? Short forceps. So this is a best example for what kind of an forceps is this? This is your wringless forceps, right? This is your wringless forceps. So in exam all they won't give this whether it is a length of a blade is short, when they will give only this forceps. So how we will identify? Mark divide the forceps. It is an they won't ask whether it is a short or a long. They will ask wringless or keelant or pipers, right? So put the mark over here and look at the length of the blade and look at the shaft. If the both are equal, then go with the short forceps, that is your wringless forceps. And next, when come to the long forceps, in all forceps, if you see, the lock will be like this. So this is your English lock. The only forceps in which the lock is in the form of the button. This button is present over here, or let me zoom in, right? So button is present over in this forceps, and here no, it is also English lock, right? So here also if you see, they will lock like this. only whenever the button is present, that is your key learn forceps. So what is this? This is a long forceps or a short forceps? Yes. Tell me. This is a long forceps, right? So look at this. Blade is small and this handle and shaft are very big, right? So this is your long forceps, right? And look at this. The blade is small, shaft and handle is big. What is this? Long forceps. So how to differentiate between this? Keeland and these pipers? Lock. By through the lock. If button is present, that is your, look at this. I am zooming it over here. The button is present, that is your keeland. If no button is present, that is your pipers. Okay. This is your pipers forceps, right? So this is about the forceps, images of the forceps, right? So keeland forceps, ringless forceps, it is also known as the outlet forceps. So we have studied lot of questions in this session. So I have taught you about how to abruptio, placenta previa, early decellers, everything is important. These are keep it, they will be frequently repeating in your exams. So thank you for hearing, guys. And forceps is very important. I taught you ringless, how do I identify? So most of the students, there will be confusion of how to differentiate the forceps. Ringless forceps. Ringless, I thought you look at the length, blade and shaft of the handle both are not equal, then go for the ringless. And in pipers and keeland both are long forceps. How will you differentiate? Button, lock. If button is present, that is your keeland. If the button is not present, English lock is present, that is your pipers. Okay. And thank you, guys, and thank you for hearing. And keep start studying and keep solving your MCQ session is very important. So what I thought, most of the questions they'll repeat from these sessions itself. So thank you, guys.